Good evening, everyone. Welcome and thank you for coming. For those of you I haven't had a chance to meet yet, my name is James Allen. I'm the Director of Alumni and Stakeholder Relations at the university, and it's wonderful to see so many people here on what is such a gorgeous Sydney evening. I have to say that Melbourne's actually been turning on the weather this week, so it's not quite the contrast that it often is. But on such a lovely night, it's wonderful that you've taken your time to join us here. And I'm quite excited about the panel this evening to think about the future of health, what lies ahead. So we've got a very diverse audience here tonight. For alumni, welcome back. We have a number of students here who are, or prospective students who are hoping to study at the University of Melbourne. Thank you for coming out and taking the time to spend an evening with us and to learn a little bit about the university. To both you and your parents, because of course we know the parents are important when making a decision of where to study, I hope you can learn a little bit about who we are and what we try to do. Before I go any further, let me acknowledge the Gadigal people of the Eora Nation, who are the traditional custodians of the land on which we meet this evening. And I want to pay my respects to their elders, both past and present, and any other elders we have here with us this evening. So there was a time when people used to think about universities as quiet places of contemplation that were separate and apart from society. This is the well-worn chestnut of the ivory tower. But if that was ever wholly accurate, and I have my doubts, we've long since moved past that model. Today, universities across Australia are sort of active participants in society, educating the next generation of leaders, seeking to answer the world's biggest problems. We are in many ways sort of engines of social transformation, informing policy, generating new knowledge about the world, and responding to some of the most pressing issues today. And the University of Melbourne, as Australia's leading university, aims to take the lead in this sort of work across the country. And so we're attempting to make a real and substantial difference to the lives of current and future generations, pushing the boundaries of knowledge and applying our learning to the big challenges that we face today. And we'll talk a little bit about that tonight. Because it's not enough to do this work, you also have to reach out and communicate this work. People need to understand what we're doing. And so we wanted to take the opportunity to come here this evening to the alumni community in Sydney and talk a little bit about what we do and why we believe it's so important. We do this because we really believe that the mission of teaching, learning, engagement are profoundly important, inherently valuable, particularly at a time when the very notion of expertise is under attack. We live in this, what is called a post-truth world. I'm not sure I believe in a post-truth world, but I'm not sure I get to make the decision on that. But this notion of expertise and the notion of evidence-based decision-making is more and more important. And so I believe that the work of universities is more important today than ever before. So tonight we've brought four fantastic University of Melbourne experts together to discuss the pressing issues of the future of health. We have an aging population, myself included. My vision fell off a cliff about a week ago, and I need reading glasses now in ways that I never have before, so I've got a very large font in front of me. And this is all good, but it raises questions about how we live and how we operate in the world. And the question is, are we ready for this? How do we ensure that a long life is also a healthy life, filled with purpose and adaptable to change? Before we get into that question, let me say a couple of thank yous. Tonight wouldn't be possible without the time and dedication of our discussion panelists, who are very, very busy people. You'll get a bit more of an introduction briefly, but we have four fantastic academics here: Professor Shaun, Professor Susan Sawyer, Professor Mark Cook, and Dr. Celia McMichael. And they've kindly offered to spend their time with us this evening and talk about the ways that their work is changing society's health and well-being. So thank you so much for spending your time with us this evening. We really appreciate it. And we're delighted to have Tony Jones as our moderator, given that he is one of Australia's highest profile presenters. I'm sure most of you are aware of Tony's work, but for those who aren't, Tony's the host of ABC TV's award-winning panel show Q&A, which has become a vital conduit for debate and discussion around the biggest issues in Australia, and a fantastic opportunity for expert debate, which is, I think, what tonight will be about. So Tony, thank you so much for your time. We're excited to have you here. I just heard a phone go off. If you have the chance, please turn your phone off. Because then we won't have that happen. I've actually made sure I turned mine off, but I almost forgot myself. So these are the kinds of things we do these days. We're also live streaming tonight. This is the first time we've done this because we have about thousands and thousands of alumni who live overseas. And so we want to make sure that people have an opportunity to hear this. We are using a hashtag for this evening, which is a hashtag Future of Health. We'll be live tweeting the debate at the UOM alumni and at UniMelb MDHS hashtags this evening. So if you happen to do that sort of thing, feel free. But once again, turn the ringer off on the phone. This is all very confusing. And we're on Facebook Live tonight, so these are all the things that happened. So that's probably more than enough for me at the moment, so I'd like to introduce Tony Jones.
Hello there. Now, yes, I am actually the Q&A host. Tonight, we're not taking any questions, and I'm quite pleased about that because when we do the program, very rarely we do it in Brisbane, and we do it in the Powerhouse, which is a big museum, and it has a huge bar. And that's the only time we have any problem with our questions is when they're a little bit drunk. I know none of you are, but I was a bit nervous when I saw the drinks were being passed around beforehand. Relax, you don't have to ask questions, and I won't come to you. But I will conduct a discussion shortly with these guys on the future of health, what lies ahead. It's a University of Melbourne alumni event, live in Sydney and streamed via Facebook, as we've just said. So hi to the alumni everywhere in the world. If you're watching live, it's great to have you on board. Tonight, we want to challenge you to think about the future of health. In 1890, the average life expectancy in Australia was 49 years. A child born today can expect to live to the age of 82. But more and more people will be celebrating their 100th birthday. So we can imagine the consequences when you think of this silver tsunami. I'm part of the silver tsunami, but I was in my 20s, so I guess I'm just getting used to being old. The silver tsunami is coming, and what impact will it have on our health budgets? It's yet to be calculated. If that's not challenging enough, however, think of this. Right now, the current cohort of 10 to 24-year-olds is the largest, I should say, the world has ever seen. We're talking about 1.8 billion young people, and yet when it comes to health, this group is the most neglected in the world. That's the strong view of one of our panellists, and we'll hear more about that shortly. As well as this, you think about the global consequences of climate change. Many will face uncertain futures in a world where some predict climate change could turn 500 million people into environmental migrants or refugees by the end of the century. So is our world prepared for the health dilemmas that lie ahead across a range of challenges? Clearly, they will vary, those challenges, depending on where you're born on the planet. In affluent Australia, for example, personalised medicine is becoming more and more sophisticated. We'll talk more about that in a moment as well with some of our panellists. We are at the forefront of medical research in epilepsy and pancreatic cancer. Hence, we've got two panellists who'll be able to talk about both of those things. It's surprising, perhaps, that epilepsy is such a big focus until you realise it's the second most common neurological condition in this country after stroke. There are, I think is it tens of millions of people around the world who suffer from epilepsy, which is untreatable or doesn't respond properly to drugs. So think about this as well. Within 22 years, pancreatic cancer will become the most prevalent cancer in Australia. And it's the most dangerous. It's the killer cancer. So more and more we're innovating, but are we doing it quickly enough? How will we ensure that a long life is also an adaptable and healthy one, filled with purpose and will benefit society? We've got 45 minutes or 50 minutes roughly to discuss these issues. To do so, I'm joined, as you heard, by an eminent panel of four, each renowned nationally and internationally in their respective fields. So please welcome, and I'll get them just to indicate who they are in case you don't know them, but Shaun Grimmond, Professor Shaun Grimmond, down the far end, is a cancer specialist. Let me just tell you about them first, and you can clap the whole bunch. He's the Director and Bertalli Chair in Cancer Medicine at the University of Melbourne Centre for Cancer Research. A year ago, he announced a significant breakthrough, discovering that pancreatic cancer is actually 4 types of cancer, that there are 10 potential pathways to those cancers. His goal is to see tailor-made treatment for pancreatic cancer patients. Dr. Susan Sawyer is a paediatrician who holds the Geoff and Helen Handbury Chair of Adolescent Health at the University of Melbourne. She's also the Director of the Centre for Adolescent Health at the Royal Children's Hospital and President of the International Association for Adolescent Health. So, no, hang on, we can clap them all in a minute. She is wonderful, but so are they all. Susan has helped establish the field of adolescent health and medicine in Australia, the Asia-Pacific region, and increasingly further afield. She was a lead commissioner in the 2016 Lancet Commission on Adolescent Health and Wellbeing. Professor Mark Cook, just immediately to my right, is a specialist in epilepsy. He's been leading a team that conducted the world's first study of epilepsy. They have developed an implant which can help reliably forecast the likelihood of seizures. He's the director of the Graeme Clark Institute, the Sir John Eccles Chair of Medicine, Department of Medicine at the University of Melbourne, and the director of the Department of Neurology at St Vincent's Hospital. And Dr. Celia McMichael is lecturer in health geography, the Faculty of Science. Her specialty is migration and health, and she's worked considerably with the World Health Organization. Her current area of expertise is environmental change and migration. She's an invited member of the International Union for the Scientific Study of Population, IUSSP, Scientific Panel on Migration, Climate and Health. A great panel. Please welcome them. Thank you very much. Now, Susan, I'm going to start with you, as I've done in the past, and we'll get you in a little while to explain what an adolescent is, because you've expanded the definition. Before we do that, governments around the world have really focused on the health of the under fives, which is a kind of noble endeavour, but you argue the health of adolescents is even more important. Yet this is the most neglected group, you say, in the world. Why is that, and what are the consequences?
Adolescence is starting younger than it ever has. The age of onset has accelerated, with puberty happening earlier in the life course. And then those social role transitions that have historically denoted adulthood are also increasing upward in age. And so within the life course, just like we're living for longer, as you were saying, this period of adolescence has expanded.
Can it expand and include up to the age of 60?
Well,
because
no.
I'd like to know if I still am in that category.
Well, no, our age range would be determined biologically, not so much by those social role transitions, as important as they are, and we won't go into yours, but in terms of brain maturation and the recognition now that brains are continuing to mature into the mid-20s, which is why we denote that upper age range. But as you said, this period has been neglected, and the challenge and it's really the opportunity of adolescence. We heard before about the transformative opportunities ahead of us in terms of health. We are at our fittest, smartest, fastest in our adolescent and young adult years, and how we mature and how we end up at the end of adolescence is hugely predictive of our future health as we mature and age. And what we haven't yet had is an appropriate suite of investments in this age period.
You're talking
apart from
globally, aren't you?
No, I'm talking about in Australia as well. Globally, absolutely, we haven't. So globally, overwhelmingly, in our near neighbour, Indonesia, for example, the definition of my field of medicine, paediatrics, ends at the age of about 5 to 8 years. But even in Australia, we have not had the range of investments we need at a policy level. And we only need to think about the Northern Territory Royal Commission in terms of young people in youth justice that we've just heard released last week to appreciate that we have this policy context wrong. We are yet failing to create opportunities for young people to be fully engaged. And I would use the example of Scotland, that a couple of years ago reduced their voting age from 18 to 16, a really safe way of getting young people engaged. And we've seen how much young people engaged in the marriage equality debate. I think that to reduce the age of voting could be very interesting. But we also need to think about how we also then support young people and young adults as they mature. So in Australia, if we look at the social support in terms of welfare that we provide to unemployed 16 to 21-year-olds, it is a third of the minimum wage for adults. This, if you are supported by your family, is just acceptable. But if you do not have supportive families, that many unemployed young people don't have, this is a road to disaster.
Just quickly, as I mentioned before, you've expanded the definition from 10 to 24. So adolescence is expanded down and expanded up. 24 is a bit extraordinary. Briefly tell us why this is. We'll come back to it, debate it possibly.
In expanding it upwards, just to say that we've had a paper that's just been accepted by the Lancet, and which, as the first author, I'm a bit anxious because we're absolutely putting it out there that we need to expand up to 24 and call it adolescence. And that is because of the upward expansion of those social role transitions. So 50 years ago, the average age of marriage for girls was 51. Now it's 30. In terms of the number of young people who are in the room in their 20s who are still engaged in education and training. It's clearly shifted upwards in age. But it is brain maturation. So over the last decades, medical science and technology has demonstrated that brains do not stop developing at the age of 8 when they are at their adult volume, but continue to be transformatively involved and shaped by biological maturation and our lived experiences as well, and that continues up at least until the mid-20s.
All right, now before I pass on to other panellists, I just want you to give us a sense of, we're talking 1.8 billion young people around the world. If we are neglecting them and their health in particular, what are the consequences globally?
Well, the consequences are we will not age nearly as well because of what I said, the patterns of health, the health behaviours that we engage in adolescence absolutely predict our health outcomes in adolescence, so the fact that we might survive adolescence, but also are hugely influential in terms of our adult patterns of health and our burden of disease. But then in particular, and you mentioned the work we did on the Lancet Commission on Adolescent Health and Wellbeing, and in that document we talked about the triple dividend that comes from investment. And the third, so the benefit for adolescents, the benefit for us as we mature, but the third aspect is the benefit of the intergenerational benefit. And that's something that we are only just starting to understand now, that the healthier that young people can be, not at the time that they suddenly realise that they are pregnant, but actually in the years leading into that, in adolescence and young adulthood, hugely influential in terms of future
so
health.
in short form, if we don't concentrate on that cohort globally, we'll pay the price later.
And in terms of paying the price later, the investment is now, some work we've done, recently published, showed that the return on that investment is huge. The benefit cost ratios are a factor of 10-fold. I've only recently learnt about what benefit cost ratios are, but I am told by my health economists that a BCR of 2 is good value. So benefit cost ratios of 10 for every dollar we invest in improving the health and development of young people, there's a 10-fold return on that investment by anyone. That to me is a good investment to make.
Stay global and stay with women, they always say. Celia, I'm going to stay global with you because the global picture Susan's talking about is a health picture which is going to be impacted inevitably by climate change and this potentially huge shifts we may see through, I think you call it climate migration. Newspapers often refer to climate refugees.
That's right, yeah.
You call it migration, I think because you think it'll be managed slightly differently than a refugee crisis. But what are the health consequences of this and what are the, give us an idea of the scale of it, what we may be facing?
Yeah, so I heard you mention maybe 500 million people might be displaced by the end of the century due to climate change impacts. And those estimates are quite fuzzy. They vary from anywhere between, say, 100 million up to even 1 billion. And the thing that's important to understand is what is going to drive that mobility. So if you take something like an environmental disaster, then people are displaced in the short term, often short distances, and will return. And that depends on the scale of the event. But if you think about slow onset changes like sea level rise, it's slightly easier to predict by just saying who's living at an elevation of, say, 1 metre, like a low-lying coastal villages or mega cities even, and are they going to be displaced? And the estimates are anywhere in the range of 170, 180 million. To put that in perspective, like the current refugee numbers we have in the world today are the highest they've been since the Second World War, and that's 60 million. So these are pretty big numbers, yeah.
Yeah, they're huge. Now, you worked with your late father, the eminent epidemiologist, Professor Tony McMichael, on the health issue. His last book was published after his death. He suddenly died very tragically in 2014, but his book came out soon afterwards, Climate Change, the Health of Nations. What were his conclusions, I guess the conclusions you worked on together about the health consequences of climate change?
Yeah, well, I mean, and we were chatting about this earlier. I had a vision of driving my own career and working on migrants and refugees, which I did for many years, but then kind of came drawn into this issue of climate change and health. So Dad, my father, Tony, brought that to the table in a brilliant way, of course, and I brought in my emerging understanding of migrant health and refugee health. So then I became very interested and realised that intersection of climate change, displaced and forcibly displaced populations and health impacts is not at all well understood. So the current policy kind of discourse is people can migrate as a positive adaptive response to climate change. So it's moved a long way from that kind of initial apocalyptic visions of climate refugees to now the global policy framework. So we need to support migration as an adaptive potential response, which is good, and it lends itself to managing migration well, but the health impacts are not well understood. And from looking at kind of analogous situations, you can see when people are displaced forcibly, you have infectious disease risk, respiratory infections, the mental health impacts of being displaced from sites that you feel like you belong. And that's what I'm really finding in Fiji, where there's these first villages that are being displaced.
I'm going to come and talk to you in more detail about that in a little while. But just give us a sense of the scale of the problem that we're dealing with in health terms, because I think it's little understood the sort of things that could actually happen. There's very little published information about this at all, and most of it's predictive, obviously.
Yeah, that's right. So, I mean, you need to think about why people are moving and where they're moving. So the important thing to understand is that people are moving in low-income contexts where they're vulnerable, and predominantly into other low-income contexts. We're not going to get floods of people coming into Australia as environmental migrants. People will move within their countries or across borders. So one issue is lack of healthcare access in those existing situations. So the usual things, poor maternal and child health. There might be gender-based violence experiences if you're looking at a disaster context. A lot of mental health and psychosocial health impacts for people that feel like, their life is out of control. They're displaced from places they feel comfortable and belong and supported. Nutrition is going to be a very big problem, I suspect, if people are moving away from places where the land has historically provided opportunity for small-scale subsistence, nutrition and living, and then you get saltwater intrusion and salination, get moved to a different place which may not support small-scale agriculture, then you get nutrition. So
it's a rich and poor world, isn't it? I mean, then the consequences for separating those even more widely clearly, it seems to me, exacerbated by this.
Absolutely. Like it's a kind of amplifier of disadvantage and social inequality. I mean, it's interesting when you get a topic like the future of health, you think, okay, it's going to be all new and emerging infectious diseases we've never heard of. In this space, it's the same things amplified. It's the same social inequalities amplified in places that are vulnerable. So, yeah.
Let me go across to Shaun. We'll get a completely different perspective now, because, I mean, we're talking about these poor populations, burgeoning youth and adolescent populations in poor countries and the potential consequences of all of this. Here in Australia, where we're so affluent, it's almost unbelievable. We're able to target our medicine very closely, and we're starting to see more and more of that. I've talked about the ageing population here. Susan's talking about the real problem being in the lower level, but we're focused on the silver tsunami and the diseases they're getting. Having lost my hair colour in my 20s, as I said earlier, I do appreciate the silver tsunami notion. But the demographies have serious consequences for health priorities and for medical research in Australia. So you're at the forefront of research into pancreatic cancer, which will soon become, as I said at the beginning, the second leading cause of cancer death. So tell us about the lifestyle risk factors, first of all, that lead to this cancer.
Sure. Look, I think, Tony, there what you've described is that here in Australia, living longer, as many of us are, is a blessing, but also a curse. There's a burden of disease that we have there. And in the likes of pancreatic cancer, this is a disease where the major risk factors are living longer, which we can't really do much about, diabetes, obesity, poor diet, heavy drinking. And if you
Do we know why those things are risk factors for this particular cancer, by the way?
So we have an understanding as to, in terms of obesity and diabetes, diabetes, all combined. It actually is a word, believe it or not. Someone can check that on Twitter. It's been checked on more than once recently. But what's happening there is that there is a lot of chronic inflammation within your pancreas. So because of that, where your immune system is in there and acting inappropriately, that leads to scarring in the pancreas, and that ultimately leads to a damage to your DNA. And as we know, cancer is caused by the accumulation of damage to your DNA, so that then leads you on that path. We've also recently seen from the fruits of a lot of the efforts we've led from here in Australia into pancreatic cancer, now start to understand the molecular basis of how heavy alcohol consumption can lead to damage to the DNA in your pancreas as well.
Okay, let's focus in on the cancer. It's best known for having killed Apple's Steve Jobs, and it tells you something, I suppose, that one of the world's richest, most powerful men was unable to find a cure, but it is incredibly dangerous and fatal in just about all cases, isn't it?
It is. It's actually, if you have a look at how we've done in terms of improving cancer patient outcomes over the last 20 to 30 years, we've done remarkably well. We've seen that the median survival increase 7-fold. We've seen overall for the common cancers, the 5-year survival almost tripling. However, when we have a look at pancreatic cancer, about 40 years ago, the 5-year survival was about 5 years. The 5-year survival was about 5%, and now it's about 6, maybe 7%. So standard oncology and all the ways we've traditionally treated this cancer have completely failed. And there's a variety of reasons for that. It's a very malignant disease. And the median, on average in Australia, when people are diagnosed, they would last 6 to 7 months.
By the way, is this what attracted you to do the research? It's sort of like the uncrackable code of cancer.
I have always been fascinated by DNA and the information that's contained within it. I started very early after finishing my degree being interested in genetics. I started to work in bladder cancer and prostate cancer. My PhD was in pancreatic cancer, and I've been on a rather wandering path looking at different aspects of that. But really what we've seen in recent years is with some huge technological changes, with the ability to decode someone's genetic blueprint, there really is this opportunity now to get stuck in and make sense of it one patient at a time.
Yeah, let's talk about it specifically. So we got the findings last year of a 7-year study of, I think it's 456 patients. You're described as the lead architect of that study, and you say it gives us a near complete playbook on how pancreatic cancer starts and what drives it. How was the research conducted? Just describe it for us.
Yeah, so this is really the fruits of Australia's contribution to something called the International Cancer Genome Consortium. This has been an enormous international effort to systematically decode the root causes and driving events within 500 patients for the 50 most common causes of cancer, which are important globally. And so I had the benefit of leading Australia's effort in that, and pancreatic cancer was our major flagship, but indeed we've worked through pancreatic, neuroendocrine, ovarian, melanoma, and contributed to esophageal work elsewhere. So we've really punched well above our weight. What this study has shown us in terms of pancreatic cancer is it shows us what are the defects that turn that pancreatic cell into a tumour. And one of the challenges we have is that the ways or the paths at which you can develop cancer is something that in some cell types can be relatively simple, and in others there may be many roads, the roads of perdition to lead you to forming that tumour. Pancreatic cancer is one that is particularly heterogeneous, so there's lots of different paths that make that cancer take off, and that's why one simple drug won't wipe out 75% of the cancers, because while they look the same down the microscope, at that DNA level in the individual, it could be quite a different set of damage that's driving the disease.
Okay, now I spoke to you last year and so I knew a little bit about that, but since then you've set up the so-called Organoid Bank in Victoria. What is it? How's it likely to impact on treatment?
Sure. Well, you can imagine if we can now decode a patient. I guess when we first started that effort, it took us about 7 months and about $1 million to analyse one individual. We can now analyse patients for about $3,000, and we do them we can do about a dozen a week at the moment, where we are with a much smaller group. So it's ready for prime time. We know from our studies that there is probably 20 different drugs that we could start to consider using on pancreatic cancer patients.
I'm going to take you back one step though, because I want to know what an organoid is.
No, the reason I'm going to explain to you what it is.
Okay, right.
So the challenge is for us now is how do we actually build up a body of evidence that if a patient develops this very aggressive disease and we've got to pick the right drug straight up, we need some way to actually to work that out.
Yeah.
Now, one of the things that
Without
we
doing
can,
it on the patient themselves.
That's correct, because really you've only got one chance, and if it doesn't work, the disease is progressing.
Yeah.
An organoid is where we take some tricks out of the stem cell biology lab book, and we are able to expand and grow the cancer stem cell, if you like, and propagate that in a dish. So we effectively grow little mini pancreases in a dish.
I've heard you describe it as a little pink pancreas in a dish.
Indeed.
I want to know how big it is, and I think it's less than 1 millimetre.
Yes, they're tiny little balls of cells, which will sit there and they grow and they communicate with one another. But it has all the genetic defects, and it's in a pancreatic cell for that individual. So now what we can look to do is not just treat that with one drug, but expand it into a plate and maybe treat it with 50 drugs or 100 drugs, either based on the information we've got from the genetics, or indeed every drug that's available in the freezer in the hospital, to see what is the vulnerability for that individual, what is their resistance profile. It's a bit like what our dream, our aspiration is to make it similar to the way that we treat a patient with with an infection, where we're looking at drug resistance for antibiotics. You get that profile as a turnaround.
Now, my dad was a bit of a miracle patient. He had stage 4 melanoma, was going to die from melanoma. They gave him an immunotherapy drug called Keytruda. It's reasonably well known, but it was a miracle cure. Cleared his entire body of melanoma, and he died of dementia. So I know that's anyway.
That's true.
I shouldn't try and make jokes at his expense, but he thought it was pretty funny himself while he still had his faculties. Anyway, leaving that aside, can these immunotherapy drugs be used in these little dishes?
So there are typically we would not be using immunotherapies and testing those in these dishes, because we grow the tumour cells and we don't grow the immune cells. There is some pioneering work being done by colleagues down in Melbourne, where they are adding the immune cells into the dish to grow with the little pancreases or the little other organoids to see what they will do. There's no doubt that immunotherapy really has been one of the most exciting discoveries we've seen in cancer treatment in recent years, and it's making huge advances for some cancers. But in the case of pancreatic cancer at the moment, it has no effect whatsoever.
Okay, so before I shift over to Mark, we're talking really here about the ultimate in personalised medicine, aren't we? Because each of these organoids is for an individual cancer, from an individual patient. There's a tremendous amount of effort goes into trying to cure each individual cancer, because they're different. And you have to find out in what ways they are different. But philosophically, do you see this as anything of a problem? When vast amounts of resources go into individual patients, it's particularly set against what we hear from the global picture of massive health crises around the world.
So, I mean, this is the challenge that when you bring more and more technology into healthcare, things get more expensive. But we have to realise that the standard of care that we have at this moment in time is not as efficient as it could be. And indeed, in some cases, it's quite wasteful. And in others, if you go through, and if anyone has been in and around cancer wards, the way that we treat patients, the adverse side effects they suffer from right now are considerable. And indeed, if you look at the likes of the costs for treating metastatic breast cancer, we spend potentially more on the adverse side effects than the actual treatment itself. This prospect of a personalised approach is designed to be more efficient. It would allow us to really pursue the vulnerabilities in an individual, not on what we'd see within a group, but it's also designed to avoid those adverse side effects. It's actually trying to shorten the odds and making that decision process for your doctor easier and better. And this isn't just going to be about should you use drug A or drug B. It has the potential of actually changing a whole slew of things around your aspects of cancer care. Now one of the things we haven't really spoken about is that while I've said that cancer arises through damage to your DNA, some of that comes from excess, bad luck, sun exposure, etc., but some of that is inherited. So there is a proportion of us who are predisposed, and there are others that are carrying risk alleles which make them more likely to get cancer. This sort of genetic information has a chance to really allow us to think about that prevention aspect as well, which once again would be
so that could have global benefits.
Absolutely.
Yeah. Okay. Let's go to Mark. You're obviously involved in personalised medicine too, to some degree. I mean, do you see any problems here? Is it a luxury that only countries like ours can afford, or do you take the view that ultimately this could benefit, a vast swathe of populations across the world?
I don't think there's any question it'll benefit the whole world. Obviously now countries with the greatest resources are able to exploit these advantages, but there's no question ultimately it will bring great benefit. I guess my concerns about it are more that we're not overwhelmed by personalised health and that we forget in there that there's a patient somewhere. And that while we can deal with complicated statistics and the analysis of these and recognise these relationships and the best therapies, it's fabulous technology, it's fabulous science, but there are enormous complexities then in relating this information back to patients in a way they can understand and letting them use this information in a way they can control it properly. And I think that's largely unexplored still, or certainly underexplored. And I do think that's a very serious problem. And I'm very interested in this area. We use this big data and we use these complex analysis, and it's fantastic. It's giving us great insights, changing the world. And I've just got this little bit of a niggle in the back of my mind.
I'm going to come back to that issue. But this whole thing about epilepsy being, I think what you said, what did we say, it was the second most prevalent neurological disorder. That's in Australia. Is that globally?
That's global. So after stroke, it's the commonest neurological disease. At least 1% of the population have chronic epilepsy. 5% of the population at least will have a seizure during their lives. So it's a very common disease, and yet I bet most people in here don't know that, and perhaps they think they don't know anyone with epilepsy, but everyone will. And I think this is the remarkable thing about epilepsy, that the stigma still is so great that it's not discussed in the same way people will discuss malignancies, AIDS, diabetes and so on. It's a terrible burden for people.
Tell us why you got into it. I mean, we just talked to Celia about her dad, but your dad had epilepsy.
That's right.
And so I'm just wondering whether that whether there was a personal crusade here as part of what you're doing.
Sure. So there was. I'd just finished medicine when my dad developed epilepsy, so he got it late in life as a complication of a brain tumour. And he was a chef, and he was very disabled by his epilepsy because he couldn't work because of it. And that's one of the most troubling bits. It's a very infrequent event, but it stops you doing almost everything. And that's a real paradox of the disease. So what struck me was that people didn't know how to deal with his epilepsy. The doctors didn't seem to have any idea what they were doing, and the treatment seemed terrible. And so that interested me, and also an opportunity arose at the hospital I was working at to start up an epilepsy unit, and so it was a straightforward decision.
Yeah, and so you've been part of like the longitudinal study we're talking about there, you've been part of a critical longitudinal study into epilepsy. Your team of researchers has been mapping brain activity so as to predict when a seizure might happen, because as you say, no one knows, and this has a tremendous impact on your life, your work, your physical activity, you name it. Tell us about prediction, how important it is and what you can do about it with the kind of research your team's been working on.
Certainly. So the problem with seizures is that, and from this, so this study involved putting electrodes directly into people's brain, recording their brain activity constantly as they were going about their usual day-to-day activities, which had never been done before. We only do this in hospital with an open skull and electrodes implanted very temporarily, but these were people walking around for up to 3-year periods where these electrodes...
Explain to us how that works. So you
so
drill a hole in their brain.
We put slightly bigger than a drilled hole in their skull and inserted electrodes over the surface of the brain in the area the seizures came from, tunnelled a wire down their neck, and under their collarbone we had a device like a pacemaker that was collecting the information and broadcasting it wirelessly to a handheld unit.
So sort of Bluetooth arrangement?
That's right, and the handheld unit displayed to them a risk in a series of lights of the likelihood of a seizure in the hours ahead. But we learnt a lot more than that because it had never been studied before what the normal pattern of seizures is over such long periods. We only do it under very artificial circumstances. And so, as with earthquakes we were discussing before, there didn't seem to be a pattern, but there is a pattern. But the reason the big data is important is you can't see that pattern until you've recorded hundreds or thousands of events. And you can do that from an individual. But remarkably, the length of time, so we've got these years of recording, but the length of time people spend in seizures is less than 0.05% of their time. And this is people in this study with very bad epilepsy. And yet, that
mostly people here who aren't responding to medication.
Absolutely, which is at least a third of that 1% of the population. So
yes.
It's still quite a very substantial proportion of people. So that 0.05% of your time can be enough to stop you working, driving, maybe getting married. In a lot of parts of the world, in a lot of parts of the third world, the stigma around epilepsy is even more enormous than in our community. People can't get married. People conceal it from their families. It's a terrible illness like that, and yet it occupies such a small period of time. So we're able to record this, we're able to recognise these patterns, and we were able to show that seizure prediction is possible.
So I'm going to be a bit crude here because scientific breakthroughs often have monetary benefits for those who can actually build the machines or make the drugs or whatever. What happened in your case? Because presumably with this vast potential market of epileptics around the world, you would have had here the opportunity to build a device that could predict when people are going to have seizures, and you can imagine the university would be delighted, of course, to have a massive monetary, and I imagine you personally would as well, massive monetary benefit.
That bit might be harder, but there's enormous benefit in doing it, enormous interest, and the demand for this sort of device is immense. However, when you do things like this, you need to involve commercial folk, and often it's hard to convince them of the imperatives. And they certainly didn't see that a procedure where you had to make a big hole in someone's head to put electrodes in, and it sounded very invasive, and it was, which tells you something about how serious the disease is.
Yeah.
People are prepared to subject themselves to these sorts of procedures. But it was clear that we weren't going to get funding for it in the longer term, and the company that had been established to create these devices collapsed. But we realised two things: that we needed a less invasive system.
So this is stage 2, so let's
Stage
go
2.
straight there. So you've invented a less invasive
We've invented a much
system.
less invasive
implant
system. Still an implant, but it goes under your scalp, so it just requires 2 small cuts to insert it. Electrodes go under the scalp, because what we did learn from the other study was that the real objective was to get lots of data. It didn't have to be as fine-tuned, because directly from brain we can get very fine-tuned data. We don't get quite as fine-tuned from under the scalp, but we get much better than we can get in any other way from other systems. But we need a lot of it. And once we've got a lot of it, we can do really clever things. So we can forecast seizures. We can give patients, even when we recorded a few hundred seizures, we can start to tell them, even over the periods of some hours, say, what times they're likely to have events. And that will then provide ways to make them safer, because obviously if you're having a seizure, blacking out, driving or doing something dangerous like swimming, that's the biggest concern. But as well, you can judge when to give treatments better. And eventually it will provide new insights into what's causing the disease and how to prevent it. At the moment, we're at that point where we've had this huge sort of abyss of unknown activity in the brain that we've never really been able to figure out. But through this study, we've collected brain activity, both normal and abnormal, and we're able to get new insights into how brain works ordinarily. And we're seeing remarkable things about the pattern of seizures and sleep cycles, and how every part of your brain represents the time of day. So your brain is a clock. There are all these remarkable things that you can deduce from brain activity when you capture it in this way. Now, our less invasive system will be a lot easier to put in, won't have quite that resolution, but it'll still let us do all of these sorts of very, very unexpected piece of work around predictive analysis.
Okay, let's go to stage 3 now, because many of us have, maybe some of you out in the audience will have Fitbits or something of that nature on your wrist, transmitting your activity to your iPhone or to your smartphone, or as we call them in the ABC, generic fruit-based devices. So I understand you're working on apps now to actually make this work.
That's right. So the Fitbit for the brain will be a combination of our implantable device and these systems of analysis. The beauty of this big data and the ability to upload this stuff to large data services where very complex analyses can be performed in real time means that you will be able to see on your phone readouts of your brain activity, and this could be linked ultimately to your heart and your activity and your sleep cycles and your Fitbit, your wrist-worn Fitbit, and we'll learn all sorts of new things from that as well.
But could it be like a weather app that you open up
Absolutely.
to see whether I'm actually going to be liable or more likely to have a seizure on?
You will open your phone and see whether today is going to be a good day for seizures and what the likelihood is and over what hours they're likely to occur. That is absolutely what you'll
It's
have.
life-changing, that means.
It is life-changing.
Because it'd be terrifying to not know, going outside, whether you can cross a road without having a seizure.
Absolutely. So it's the unpredictability that is the key, because it leads to the hazard, it leads to the humiliation, it leads to our inability to judge when therapies are working. And at the moment we judge all of our therapies according to patient diaries, and we've shown as well through this study that these are woefully inaccurate. They bear almost no relationship to what's actually happening. So at the moment all treatment is based on this, and all new drug development is based on diaries, which are almost meaningless as it turns out. So this will change everything.
Let's hope so. Back to Australia, Susan, and your research divides the world into 3 categories: low, middle and high income countries. Australia is a high income country. What are we doing in the field? How are our governments responding to this adolescent group, this 10 to 24 year group as we now must call them?
Look, in some areas I think that we're doing very well in Australia, and in, for example, tobacco control and the rates of smoking in Australian young people are among the best in the world. But in other areas we're not doing well.
Is that because governments tend to be very short-sighted, looking only
the
across the electoral cycle?
As I was saying earlier, I think one of the problems is that we haven't had a consistent, if you like, a conceptual mud map, a framework for how we think about the health problems that affect young people, and then particularly how we think about preventive efforts. What Mark's been talking about here is all about a focus on, prediction and on prevention, really. That's where we're wanting to move. The risk factors for pancreatic cancer, obviously very much focused around prevention if we can get there. But when we think about preventive strategies, too often in terms of the health issues affecting young people, whether we're talking about tobacco, alcohol, substance use, whether we're thinking about mental health issues, the focus is very much in terms of a response around treatment, and it's a very medicalised response. Because when we think about the issues of prevention, a bit like what Celia was describing in terms of the challenge of migration and a loss of identity, a loss of a sense of connection to others, what we know inherently from all of the work that's been done across the world around adolescent health is that young people do best when they are educated, when they are engaged in pursuits that they find interesting and that they become passionate about, and when they are protected around a certain risky framework. And much of what we've done in terms of prevention in Australia and in other parts of the world has focused upon educating young people about risks. And I don't know about when you were young. I won't share some of our earlier... Actually, I do know about you were young. I will share some of our earlier conversation, but clearly risks about... No, okay. But education doesn't do much to change most of our behaviour.
Didn't help me at all.
No, not me neither. So, my University of Melbourne education might have changed something in terms of a risk profile, but my broader education in terms of understanding about tobacco or alcohol made no difference whatsoever. What we know does change behaviours is what we now think of as policy nudges, if you like. So the reason we've been successful in Australia in terms of tobacco is not because we provide education to young people in schools, although that is part of the attitudinal shift. It's because we tax tobacco at one of the highest rates in the world. It's because we have plain paper packaging. It's because we have bans on tobacco in public spaces, such as in this building. Think back to the days of aeroplanes when you used to be able to smoke there.
So should beer cans have pictures of fat people with diabetes?
Well, I think we need to be thinking about the policy environment that shapes behaviour. So, for example, if we think about drivers, the biggest cause of death to young people is from road traffic accidents. And Australia has arguably a pretty high rate of road traffic accidents in the world, including in terms of when you look at our rate of miles per young people. We have graduated licences in Australia. So you're forced to have a certain number of hours before you're forced to get your L plate, before you then have a P plate, and you're not allowed to have any alcohol in your system for a number of years. Those sorts of policies have been incredibly powerful over the years in terms of shaping adolescent drivers' behaviours in ways that are incredibly helpful for them. We need to be doing more of those sorts of things. But these are the sorts of public policies that we need to be thinking about. But just to finish, I mean, I think the major opportunity I think we have, if we think about the populations that are perhaps most at risk in Australia at the moment, are the population who are disengaged prematurely from secondary education. Someone mentioned earlier in terms of Indigenous young people and the concerns in terms of their very unequal health outcomes. This is incredibly worrying, and their very early disengagement, even in primary schooling, is something that we really have to be spending
the terrible
time
risk
about.
of self-perpetuating activities like alcoholism you referred to, and the potential for fetal alcohol syndrome, which basically gives you intergenerational problems.
Exactly. So if we can retain young people in schools and find ways that education systems become inspiring places for young people, as inspiring as their iPhones might be, and engage them in learning the sort of skills that young people are needing for employment, which has radically changed from 50 years ago. This is where the opportunity really is.
All right, so opportunities for governments. Celia, how's government done with climate change, and particularly the potential regional consequences?
Yes.
And now you can talk about Fiji.
Well, I was hoping not to get the Australian government question, actually, because we did promise we wouldn't talk about the Adani mine. But,
Well, perhaps the
Go
Adani
Celia,
mine,
now you've got a chance.
perhaps the mining corporation should simply be paying into a fund to relocate Fijian villages from close to the water.
That is a good idea. Yes, they should. So the Australian government, well, we had AusAid, which got shut down. We now refer to that as WasAid. And so it's DFAT that now takes the responsibility for climate adaptation funding. And they operate in the Pacific. They support climate change adaptation initiatives. And although our international aid budget is reducing, we still contribute funds in that way. So the government is doing something in that respect, and we've made our targets to meet climate change greenhouse gas emission reductions. I won't get into it. This is a debate we all know well about whether we're doing enough, but I would say that things like Adani mine, they did not send a good message to the Pacific.
Yeah.
So the people, where I work in Fiji, it's a lot of low-lying coastal villages that are facing an environmental future of being moved. And the narrative there is pretty strong, like the big countries pollute, the small countries suffer. And I heard that so many times. It's a real global awareness. Even though this is a local problem that people are experiencing, they're seeing shorelines come in by 15 metres, 20 metres, houses being washed away. I mean, you can, they're iconic images of the footings of houses out to sea. And people, being forced to start to move up hills.
Well, this is the interesting thing, because I didn't know this was already happening. And in Fiji it is. So tell us about that. How many villages will need to move? How many have moved? How are they paying for it?
Yeah, so the countries we all hear about are Kiribati and Tuvalu, because they're the low-lying, the whole country is 1 to 2 metres above sea level. Fiji is mountainous, so it's not the first country that comes to mind. But of course they have low-lying coastal villages, so they're trying to be quite on the forefront. And what happened is in Fiji, villagers approached the government, so it's community-led. And I know before I was talking about all these health risks, But this is almost a bit of a good news story in Fiji, that local villages and what's called the Tarana Nikoro, the head of the village, is saying, going to their provincial council saying, we want to move. And the government has chipped in some funding, and they're coming up with some funding themselves through, you know, selling natural resources like hardwoods, and then
So chopping down their own forests.
Yes.
That doesn't sound like a great idea.
No, it is not, but when it's the only resource that you've got, the only way you can raise money, and it's...
So what percentage of the villagers have to put into this fund for moving their own village?
About 25%, and
Right.
it costs about $500,000 Fiji to move the village up the hill. But now they're saying they need to move 81 villages, and that's going to be very expensive. And then since then there's been Cyclone Winston, which soaked up a lot of funds. So Fiji government and the Climate Change Unit are now saying our main role is to access international funding. And there's a lot of discussion. Fiji headed up the Conference of Parties in Bonn, and they really put it on the table. We need funding for adaptation, we need funding for loss and damage, and that is a contribution that high-income developed countries must own up to.
All right, we're nearly out of time. Yes, I am told by Verica, we've got 5 minutes. I'll devote it a little bit to a discussion that Mark started off a bit earlier. It was about big data. And I'll start with Celia, though, because climate change is all about big data, isn't it? I mean, the modelling for what might happen is the data on which all these predictions are made, and therefore it's led us to do all the things we're doing.
Yeah, it is all about big data at that scientific level of how much the sea level is going to go up. But of course, from the perspective that I work at, it's not all about big data, it's about local experience.
It's about a personalised medicine version of your work. Yes.
Yeah,
Indeed.
and trying to make sense of predictions of a future. I mean, for Pacific Islands, if we assume greenhouse gas emission trajectories of business as usual, and you see these really confronting graphs of sea level rise of 1 to 2 metres, it doesn't leave you much of a viable future in that big data set. But they're saying, well, let's not assume that's a foregone conclusion. If the world actually urgently and drastically cuts greenhouse gas emissions, we have an alternative future where we may not have to be displaced. And that's a much more personal story.
It's the Kiribati making a decision not to move at all, just challenging the world to not see them up to their necks in water.
Yes, because they have been talked about so many times as having this concept of migration with dignity, which is a pushback on that climate refugee discourse. We're not victims, we're not vulnerable, we're going to migrate with dignity. And it became a very powerful discourse that was known, but the president is now saying forget it. That is giving everyone an out. We are not moving, we're staying put, this is our homeland, we have a right to live here, and we're not going to accept displacement and forced relocation as a future.
All right, go back one step. Mark, big data. You obviously use it, it's important, you've acknowledged that, but you have concerns. What are they?
Well, I guess there are a lot of concerns about, I mean, we'll all be familiar with how Facebook information can be used in unexpected ways, not always to your benefit. For instance, I read of one recently where there are groups who can scour through people's messages and figure out how many times they say awesome and how many exclamation marks they put in, and figure out that they're bad insurance risks for cars. Right? Seriously.
Yeah.
And there have been even worse examples than that. Now,
Well, how about in medicine? Let's stick to where we're at.
so, no, but it's the same point. So this stuff's easy to use for the wrong reasons, and insurers are obviously a big concern from the point of view of the medical world. Once people can get hold of this data and control the risks that they provide to people, it changes the dynamics of society quite
Does
considerably.
it change the dynamics of your relationship with patients?
Absolutely.
Why?
It does, because I don't think most doctors are sufficiently equipped to discuss these issues with patients, and they're certainly not. For instance, now, even with the genetics that's available, most doctors are not equipped to discuss the implications of the genetic studies which are available now and coming with results to doctors to their patients, and their patients certainly aren't in a position to be able to interpret this appropriately. And I think that's a very serious problem.
Shaun, do you think it's a problem?
Yeah, I do. And I think we're seeing that this technology is being embraced right across the world. In terms of the protection of patients and that information, Australia is one of the few Western countries that we don't have genetic discrimination legislation, and that is a deficit. I think that where this information is being used right now, we have to be using it in a measured way. I think if someone is diagnosed with the likes of pancreatic cancer or brain cancer or other cancers of poor outcome, there is an immediate benefit there, and we can weigh up those risks. I think the idea of going out and sequencing every healthy baby from January 1st next year is a terrible idea, because we have to get the protection in place. And we have to learn as professionals, and then I guess also as a community, how do we actually use that information for good. And there's a lot of things there at the moment that where we don't understand risk and we don't understand what genetic differences might mean. And remember that we are not the sum of just our genetic information. It's all those cheeseburgers and everything else you eat to give you the diabetes. So that your environment is also a huge part of that. So we've got to actually understand where the utility is and use that where it's needed most in sick individuals, but also start to build up how do we protect ourselves better as genomics becomes a standard part of life, which it will do in the very near future.
I was going to get everyone, because to finish up, get everyone briefly to pitch forward 20 years. I know it's incredibly difficult to do, Shaun, but in 20 years, will you be able to cure or treat pancreatic cancer as a chronic disease, as many cancers are now treated, do you think?
I think that within 20 years we would have seen a quadrupling of survival within pancreatic cancer. There's a number of groups there that right now we can start to target. I see that genome sequencing will be the cost of an X-ray. Anyone who goes in with cancer will have that done. We'll be having blood-based screens being done, scanning you for the prospect of early detection of cancer. The other thing that 20 years ago it was chemotherapy, 10 years ago it was what we call targeted therapies, where we try to make a drug that targets a single mutation. This decade is immunotherapies. The next decade will be vaccines to your individual cancer. And you may have heard of CRISPR technology, this fantastic new approach. They're actually seeing how you can use that now to target cancer cells. I really think we're going to see some substantial changes with all of those things being used, even for some of these most difficult cancers.
Okay, Susan, in 20 years, let's say your older adolescents will be in their 40s. They'll be in their 40s, and if nothing is done, if this neglect that you talk about continues in 20 years, what are the health consequences for that group now entering middle age?
I mean, I think the health consequences are going to be pretty clear, that for the group that's entering into middle age, that they will have a burden of mental disorder in particular, a burden of substance use disorders, and a burden of obesity-related diabetes that we as a community will not be able to afford. And therefore the investments that are required now to think seriously, and probably obesity is the area that there has been least traction in terms of moving from the notion of obesity as being a single individual related behaviour change to needing to think about public policy responses to food accessibility, food cost, that helps again nudge behaviours into much more healthier ways, changes access to public transportation, moving things beyond a health sector set of investments to recognising that this is multi-sectoral in its orientation. If we don't do this, we won't be able to afford any of the wonderful future technologies that I certainly want access to as I'm ageing. So I'd like these guys to be continuing to do their stuff.
Well, let me throw across to Mark, 20 years. Epilepsy, will it be just completely manageable, like having a cold for part of the week?
Yes, in 20 years we'll be able to use a similar technology to what Shaun was describing, take out cells, figure out which drugs you'll respond to. Through the implanted systems we'll be able to see if you're responding to them appropriately, and you'll be able to manage all of this with external devices that provide some practical means of managing your life.
And Celia, in 20 years, will the world be totally powered by a combination of renewable energies and nuclear power?
Yes.
So we'll all be okay in the long run, is that what you're saying?
Let's hope so. I mean, I think it's promising that we know that those technologies are available. I mean, you see what's happening in China. We have a solution. We are powering towards that in China and other places. So optimistically...
Well, they have to realise if no one in Beijing can breathe, they'll have to do something.
Yeah.
That's where all the politicians are.
And China has some mega cities of very low coastal elevation. So, 20 years I think is perhaps too tight a time frame. But in, say, 70 years, 80 years, people are going to move. But if we transition to a low carbon economy, then a lot less people will.
That's what we'll have to leave our panel. Brilliant panel, I might add. Please thank them. Shaun, Susan, Celia and Mark, thank you very much indeed. That's all we can do now. But you'll be able to go and chat individually with these guys in the period after this discussion. I think that's being encouraged, so take your opportunity.
Let me just say a quick thank you to our panelists, including Tony. Thank you so much for this evening. It's been a fantastic evening. Shortly, the doors behind us will open here, and we'll head upstairs up to the 3rd floor. There are some lifts to take us upstairs, and we can